So I hope everybody's safe in this era of COVID-19 pandemic. And I'm here to today talk about pediatric asthma, the sunshine vitamin as an adjuvant therapy. Now, I'm working as an assistant professor at DY Patil. I did my pulmonology fellowship in pediatrics. And for the last 8 years, I've been exclusively working a lot of research, me and my mentor, Dr. Lahiri, have been doing on pediatric pulmonology aspects. So quickly, as we're running out of time, and I like to have more of questions rather than just having a one-way talk. So let's start. So why asthma again? Why vitamin again? So before this COVID-19 pandemic, actually we were dealing with a pandemic which is related to vitamin D. Okay, every single person, every single I think part of the country and the world were very excited to just do research on vitamin D. But because it's suddenly everybody found out that not the skeletal aspect, but vitamin D is more now linked towards metabolic, endocrinology, cardiovascular, so on and so forth. So why bronchial asthma? Now, as we continuously keep talking about this, obesity, diabetes, hypertension as non-communicable disease, I'm sure we should take bronchial asthma in the same breath, because as I've written on my slide, is the 16th amongst the leading causes of years lived with disability. And if you see the disability adjusted life years, it's amongst the 20th, so it's like it's really something which is an alarming thing for us. It's known as a reversible obstructive airway disease. Now, why road? So why am I stressing on that reversibility? Because the earlier we pick up asthma in children, we be able to treat it, okay, with the inhaler therapies, or how we classify according to our guidelines and classification and so forth, and we can treat it, okay? So it is reversible. So we will try to, save everybody from going into that morbid situation. Prevalence in India, with the global report, which was reported somewhere in 2016, the prevalence is 7.24% in children. And as you all know, that it's going on increasing. And also, basically, we need research studies which are required in covering all aspects of asthma, be it the compliance of the treatment, be it the responsive treatment, be it the comorbidities which are associated with bronchial asthma. Please remember, bronchial asthma per se is actually like a syndrome complex. A child having bronchial asthma will definitely have comorbidities in the form of allergic rhinitis. As one speaker before me talked about, obstructive sleep apnea, from gastroesophageal reflux disease to recurrent URTIs, that is upper respiratory tract infections, that is tonsillitis, pharyngitis, otitis media. So yes, the child, and especially because I'm only stressing on pediatrics, I will just say that. So it's a miserable thing for a child, to handle so many things at one point of time. And the most difficult part is that when we say what is the etiology of bronchial asthma, it's very complex. It's right from genetic factors to the level of immunology to somebody susceptible because of because they're staying at a place where pollen and allergies is too much, or there's a lot of urbanization which is happening in the world. So probably these are the factors, and we can't just pinpoint one particular person that, okay, why my child? Like, parents keep coming and asking me, madam, why my child only? Ma'am, why my child only is having asthma? So you just cannot, if risk factors are not there in the family, so why? If he's not had any time atopy, so why he or she has developed asthma? Another thing is, so this vitamin D, we're going to come to this role. So I would recommend with this presentation that definitely we have to use it as an adjuvant to conventional inhaler therapy, and I'm here to convince you why. Okay, so let's go in for the next slide. So just a general thing about vitamin D. These are the normal levels, which are 20 nanogram per ml, insufficiency, deficiency, and toxic, which is displayed. Now, this is according to the consensus of the Indian Academy of Pediatrics, where we have devised that, okay, these are the levels. After doing these cohort studies and a large cross-sectional studies, we have decided that, okay, these are the levels which we are going to tell are normal, insufficient, and deficient. Okay, so this is also something which you're going to later discuss, that each region has devised their own levels. Okay, but by and large, they're your 5 or 10 nanogram per ml here and there. So what is vitamin D? Basically, it's a fat soluble vitamin. It's a corticosteroid, and more than a vitamin, now it's been tagged as a hormone, because it works at the cellular level. And something which works at a cellular level, which affects your immunity, which is the basis of your immunological development, right from the time you're born till how your lungs mature. Definitely, it's nothing more or less, nothing less important compared to a hormone. Okay, so we have how just a little word about how it's produced. You have from the skin the UV rays which comes in, D3 7D hydrocholesterol, and then you have the ergocalciferol D2 food which gets converted in the liver to 25 hydroxy vitamin D, again gets converted into the kidney into the active form, and then it binds to the vitamin D receptor. Now why have I highlighted that part is because you have to understand this vitamin D receptor. When vitamin D interacts with this vitamin D receptor, this vitamin D receptor is very, very important in acting at all the inflammatory and immunological responses. So any defect at that level, it's important for gene, transcription. So basically any defect, okay, any defect at this level definitely is also, studies have shown, has been linked to bronchial asthma. Now, coming to why has vitamin D gained so much importance? As I said, that before COVID-19, I think for the last 7 to 8 years, everybody's just been doing research or probably writing review articles or probably doing original articles, on research on vitamin D. Why is it so important? Now, especially this vitamin D deficiency in general is because the people who stay, have got winters as a predominant climate, people who stay at high altitudes. We have religious practices where people, cover their faces, like certain sect of, religion, which generally, covers themselves completely. Like especially in the Middle East countries. Then you have this urbanization which is coming in, generally, people have stopped playing outdoors. I think the concepts of outdoor playing has also reduced with the coming of the technology. Everybody's sitting with their iPads, with their phones, so that human interaction is reduced. Everybody's only into their phones and laptops these days. Then, staying indoors, the pollution which is there, when people ask me, no, there are places, there are countries where there's a lot of abundant sunshine. So, that would be adequate, to produce vitamin D. No, my point is no, because with the amount of urbanization, what we're adding to the pollution, so we don't get that, completely unpolluted, sunshine, which probably can, stimulate vitamin D in our bodies. And then the diet, which is associated. Now, as I told you, that asthma is associated with a lot of comorbidities. Okay, so one of the major comorbidities is, or one of the major issues which, asthma children do have, is food allergies. Now, the diet which is associated which is rich in vitamin D is, we're talking about egg yolk, we're talking about dairy products, we're talking about fish. Okay, so if you go into these histories, many children are, allergic to dairy products. They are allergic to egg yolk, or they are allergic to egg in general. They are allergic to some forms of fish as well. So, here we are again, it's like a catch-22 situation where you advise dietary, if suppose they're allergic, again it goes into that vitamin D insufficiency state. Now, what is the role of vitamin D in asthma? Let's just go, this is just a briefing, and then we'll go individually. So first is an immunomodulator. It's an antiproliferative. It's got an antimicrobial, antioxidant, as well as antibacterial effect, and it helps in steroid responsiveness. Now, coming to the immunomodulatory role. Now, as we see, if you can see this here, I don't know where my pointer is going. Okay, so as you can see on the screen, you have the T helper cells, which are whichever allergy is there, it just stimulates the T helper cell, T helper 2 cells in our body, and releases interleukin 4, 5, and 30. So basically, vitamin D suppresses this inappropriate Th2 response right from the step 1. So what happens is, whenever the Th2 cells are stimulated, then again they act on the interleukin 4 acts on the B cells and releases these IgE, immunoglobulin E. And then it acts on these mast cells, and Ig acts on these mast cells and releases histamines, leukotrienes, and other inflammatory mediators, which basically is responsible for the basic pathology of asthma, that is the inflammation and the hyperactivity and the bronchoconstriction. So what does vitamin D at each step? It has got some role. First of all, as I said, in step 1, it can suppress the inappropriate Th2 responses. It can reduce the class switching to IgE synthesis. And the last one is decrease mast cell activation. So at all the 3 steps, vitamin D is helpful. Am I audible? Am I audible to everyone?
Yes, you are.
Okay, yeah, okay, thanks. Then we have the next slide is about antimicrobial and antiviral. Okay, so now as we know that asthma, the main triggers are generally these upper respiratory tract infections, and most commonly you have the viral. Okay, all the viruses basically, I think, name it, and they can stimulate an attack in an asthmatic child. So it's very important that vitamin D having an antiviral response is like a huge, boon to us, and definitely just one of the major reasons why you want to give it as an adjuvant therapy to the normal to the actual the classical therapies which we give. So what happens is it blocks the interleukin 33. Now what is the importance of interleukin 33? This interleukin 33 basically impairs the body's appropriate antiviral response, and it also promotes eosinophilic inflammation. Okay, so one thing it does is blocks this. The second step is it enhances something called as cathelicidine, which is an antimicrobial peptide production. Okay, and its vital response both. So it basically enhances this, so it responds to both. It's vital in viral also, as well as if the child is affected in bacterial infection. And the third one, there are a lot of meta-analysis done which shows that vitamin D supplementation itself, suppose you give it to a child who is an asthmatic generally also, who's deficient, it reduces acute respiratory tract infection. So like a major chunk which actually can exacerbate asthma and can actually precipitate these episodes, that basically can be inhibited by vitamin D itself. Okay. Now coming to the vitamin D and steroid responsiveness. Now one thing which is there is when we talk about this certain section of children who are not responding to steroid, or we call them as steroid resistant class of asthmatic patients who are with probably grading of moderate to severe. So what happens in them is this multifactorial, like the bacteria like H influenza B, then you have oxidative stress, vitamin D deficiency itself. So all these three factors per se cause steroid unresponsiveness. So what happens in vitamin D? Vitamin itself, when you give vitamin D, obviously it has an antioxidant and antimicrobial effect, as I've explained in the previous slide. It enhances the production of interleukin 10, which has got a major anti-inflammatory action, and suppression of this T helper cells, which are 17 response. What happens is when this T at 17 is stimulated, you have the release of interleukin 17. So what they have found out in studies is that when you give, when these particular steroid resistant patients have got a high, a level of interleukin 17. So that suppression is, interleukin is suppressed by suppressing the Th17 responses when you give vitamin D. Now coming to anti-proliferative actions. Now, when I went through studies and at this basic level of pathology, there are a lot of actions, but I'm just trying to, share the few things which will, which will be like remaining with you all once you go back, to your respective places, that you'll know exactly, yeah, these are like probably will be the take-home messages. So I'm just highlighting only what are very, very important and essential. Otherwise, there are a lot of studies and there's a lot of matter and a lot of literature which is being written. So what is the anti-proliferative action? It inhibits the airway smooth muscle proliferation. Now you have to remember that mainly the vitamin D acts on the smooth muscles. Okay, so what it does, it inhibits this MMP9 and ADM33. This MMP is basically matrix metalloproteinase, and ADM33 is again a metalloprotease. So these factors are important in they basically act on the airway smooth muscle and cause bronchoconstriction, hyperresponsiveness, and narrowing, and airway inflammation. So all this is basically inhibited by vitamin D. Once you give that, it basically acts as an anti-proliferative action. Now coming to studies, now where do we stand? Now we've spoken about why it's a pandemic. We spoke about the normal levels. We spoke about why bronchial asthma is definitely the most important disease complex which we need to really focus on. So in these studies which we have done, what I have picked up is the last 5 years, whatever relevant studies had been done with vitamin D. We just go through certain results of each of the studies and come to a certain conclusion. So in 2014, Yadav et al. Had done this studies. There were 100 patients. I'm only talking about pediatrics here. So there were 100 patients, two groups, where one was given vitamin D, 60,000 international unit, and other just a placebo. So they found decreased exacerbation. PFR, the peak expiratory flow rate, was significantly increased. They found out that the emergency visits had decreased, and there was decreased requirement of steroids. The next studies in 2016 was done with trying to find out what was the asthma control when they had given a low dose of vitamin D to a certain section compared to the placebo. So 89 patients were taken and two groups, and they were divided. One was given low dose 800 international unit per day, and the other for 2 months. And patients were then, means they were given for 2 months, a placebo and vitamin D, and then they were assessed at 2 months and 6 months. In that, it was shown that asthma control improved, and the peak expiratory flow rate, which is less than 80% predicted, was significantly less. Usually it's more than 80%. So when they did the peak flow, they saw that the 80%, less than 80% predicted values were very less once they gave vitamin D. Then coming to 2015, somebody did a systematic review and meta-analysis, and they found out that they found out that eight randomized control trials they had studied, out of which they were age group of 3 to 18 years, and they were around 573 patients. So they came up to one randomized control trial which said that there were lesser emergency department visits. None of the other studies actually studied about hospitalization or how they responded, and they also found that there was reduced risk of asthma exacerbation, but this particular study which they had picked up was of low quality. Then one of the studies in 27 was done by me and my mentor, Dr. Lahiri. We took 66 patients, divided them into two groups, and one was given 60,000 international units once a week for 10 weeks. And we compared it with the second group, which also had asthma, but we did not give vitamin D to that. And the PFTs, the pulmonary function tests, were monitored. And the group which received vitamin D, we have found that there was a significant improvement in all the parameters which are used for diagnosing asthma and monitoring asthma therapies. That was the forced expiratory volume in 1 minute, FVC, the forced vital capacity, the FEV1 to FVC ratio, and the peak expiratory flow rate. So we significantly found out that definitely they were followed up after 10 weeks. Then we followed up with the PFT, and we found out there was significant improvement in the group which was monitored, administered vitamin D compared to those. And these 66 patients were all deficient patients, vitamin D deficient patients, and all those who in age group of 6 to 12 years who could even perform the PFT. Then coming to a study which was done, this vitamin supplementation to prevent asthma exacerbation. This was just a study, means a systemic review and meta-analysis was done in 2018, and the Lancet it was published. There were around 483 unique studies, and 8 randomized control trials were done. This is obviously the adults were included in this. Total 1078 participants were there, and individual participants' data were there, and 7 studies were there. So vitamin D supplementation reduced the rate of asthma exacerbation requiring treatment with systemic corticosteroids. So they significantly found out that. So when they gave vitamin D, the exacerbation had reduced. Then coming to another study which was done in 2020, they basically wanted to find out the association of 25-hydroxy vitamin D with asthma and its severity in children. Case control study was done. Again, there were 520 patients, which was divided into 2 groups, cases and controls, and 25-hydroxy vitamin D levels were studied in both the groups. So when they compared, they showed that there was vitamin D levels showed statistical difference between the 2 groups, and however, how much ever the asthma severity was there, the vitamin D levels were low. So what I need to what the researchers are trying to find out that whether it's like a circle, vicious circle which is going on, like when you have asthma, so you have vitamin D deficiency, or then when you give vitamin D deficiency, the asthma control or the treatment improves, or is it the other way around, or is it like a vicious cycle which goes on? You have vitamin D deficiency, you're prone for an attack. Again, because of the attack, again you get vitamin D deficient, because there are various factors, giving steroids, etc., where you stay, how much is the exposure, etc., etc. So basically, they're trying to find out whether it's like, is it a reverse causal relationship or other way around? So basically, it's a just try to combine certain things with the whatever we can do. There were other studies also which I have been reading, where they did studies when basically vitamin D is also involved in the fetal lung development. Many meta-analyses were done. So they also suggested that all the pregnant women who are vitamin D deficiency should be given vitamin D. And then because then they followed up these children up to 3 years of age, and they said that the episodes of wheezing or recurrent wheezing was less. But I feel the only issue in this is that asthma generally, you cannot pick up when the child is around 6 months, one year. Generally, it's unlikely. They get repeated hyperreactive airway disease attacks, and then on they go on to develop asthma. So basically, we need to probably follow them up for a longer period of time, but definitely it has shown to be beneficial. So now they've recommended that all the pregnant women, or probably around the periconceptual area, or when you're planning your pregnancy, to definitely check the vitamin D levels and assess that, because vitamin D level itself, right from fetal lung maturation, as I said, to the development of the lung, it helps at every level. So now the take-home message would be that you need to screen all the pediatric asthma patients. My answer would be definitely yes. You need to screen all the pediatric asthma patients. For me, if given a choice that yes, I would give the benefit of doubt, it's going to definitely benefit this particular child where he or she is wheezing and is on steroid inhalers, and if it acts as an adjuvant and is definitely going to help at every level, right from the immunological response to the therapy itself, which is steroids, which is the mainstay of the treatment, definitely I would definitely give vitamin D. Then optimum dosage recommendation. Now this was also a debate going on, that ongoing debate that yeah, whether we should give a 60,000 international unit, should we give those high doses, or whether should we just give 800 international units to 1,000 international units and then check. So that is one thing which we need to work on, that what would be the probably the optimum dosage recommendation. Should we give them a maintenance dose over a long period of time, or first probably treat them with the bolus and then give them a maintenance dose? I would suggest if there are deficient levels, yes, definitely you can give that 60,000 IU a week for 10 weeks, and then maintain, you give the maintenance dose completely till the child is not off the inhaler therapy, or probably however long the child follows up for you. Then defining what are the optimal levels where the concentration of serum 25 hydroxy levels are enough for assessment. Now what they've been saying is that defining, as I said, optimal levels. Now Indian Academy of Pediatrics has come with these levels, so we are going to follow that, because this is what is in our area or in our country. This is what is the levels which have been decided after a cross-sectional studies have been done. So I think each country should probably define this is our sufficient, insufficient, deficient levels, and then probably giving the dose. There are even debates ongoing on whether serum concentration of serum 25 hydroxy levels are enough for the assessment, because they say that it's very variable at one particular given point of time when you do each person. So it's very variable, because vitamin D per se levels also many factors affect an individual who's deficient, sufficient, or insufficiency. So that has to be again decided. Then recommended as an adjuvant therapy, definitely I said that I would always, if there is I would always give the benefit of doubt, and definitely we in our pulmonology clinic definitely screen all the patients for vitamin D, and if there are low, we recommend them with the treatment, and then we put them on maintenance dose. It just depends upon what is their levels, and that's how the treatment goes on. Now we need larger trials to be conducted with long term follow up. Yes, that's something which even I agree to. We need to do larger trials, but I feel that just continuously waiting for the larger trials to happen and then come to a conclusion that yeah, we should give vitamin D or we should not give vitamin D, I think that's something which we should not be sitting and waiting. If a larger trial wants to be taking place for, yes, definitely, because please understand, asthma, as I said, is an immune complex syndrome. So we give the inhaler therapies, the compliance, the way they take the therapies, it's very important. Right now, whenever we talk about asthma at any forum, bronchial asthma in children, we keep on stressing on the fact that they have to be compliant, they have to come and follow up, they have to come take the treatment regularly, because there are a lot of financial and economic burden also which comes to a patient when it, because the regular follow-ups, the emergency visits, the hospitalization, and if all can just be taken care by a single vitamin D, then definitely I think, we should not be waiting for the trials and, then, suggest for some recommendations and some, again, guidelines come in and then you give it. Okay. Because I have gone through many studies and nowhere definitely I have seen that when you give larger dose or maintenance dose, anybody has ended up in the hypervitaminosis D situation. So I have not come across any article, nor it has been commonly reported. Then maintenance dose, I said, of vitamin D, it has to be given. We are doing that. Once we treat the levels, we get back to normal, we repeat the levels, and then we give them as a maintenance dose. Because I would say that if there is any kind of area of hope in the treatment of pediatric asthma, even adults for that matter, we definitely would give them that as an adjuvant, which will take care of everything, right from the upper respiratory tract, the steroid responsiveness, to the immunomodulatory effect, to being prone to bacterial and viral properties, etc. So this is something which I need to. Another thing, we are dealing with COVID-19 right now, and I can really tell you that in the last 4 months, I'm sure there must be lockdowns in different countries of the world, and we are going through one. So in the last 4 months, I mean, I don't know whether it's a blessing in disguise, but I have generally not seen patients coming with any kind of an asthma exacerbation in the last 4 months. Everybody has been controlled, probably because they're not going out, not taking those those food items probably which cause allergies. They are they're not going out in pollution. You don't have dust or etc., which probably in our country though it's really rampant, the amount of pollution which is there. So I mean, all these things definitely have worked. So I don't know whether I could put it as COVID-19 being a boon for pediatric asthma. If yes, I mean, if that's the way, then yes, because in the last 4 months, I haven't, hardly seen any kind of an exacerbation. In home, the children are actually more safer than, what it was before. Yeah. Thank you so much.